a urologic surgeon. We need to avoid the ideal candidate is somebody that typically has lower volume, low grade, typically Gleason grade group 1 or 3+3=6 disease. Low PSA, meaning preferably less than 10. African American race. I don't think that necessarily race alone is a trigger to say we need to do treatment rather than surveillance. Age, amazingly, is the same thing, because you're only 50 and maybe 30, 40-year life expectancy, there's a good chance you'll be treated before 70. As opposed to if I see a 70-year-old, then it is a matter of if they'll ever need to get treatment. So I think younger men kind of eventually are going to get treated if you look at the data. But that doesn't mean they need to get treated when they're young. We should try to find those who could be on inactive surveillance. In other words, we do biopsies every couple of years or every year in some cases, that don't need any biopsies for 5 years or 6 years or 7 years, because there's almost no chance they're going to have something worse that we find. Why go through all those biopsies? They're painful. They have infection risk, bleeding risk, psychosocial risks. Like you said, there's worry and anxiety concerns. And so we should be able to find that group of patients that doesn't need to have surveillance very intensive. With a 3-4, there is even some debate in some circles about 3-4 disease. I mean, the ideal candidate is 3+3, but your listeners and your followers know all these little nuances. And so with 3-4, there is still a debate out there about whether we should be surveying. And I do think that we probably overtreat some of those 3-4s. We probably do. But I think it's just because we as a physician team are risk averse, don't want to miss that window of curability. There is also a bit of controversy as far as how often we should see patients, how often we should do PSA measurements, how often we should do biopsies. All places do it differently. I think the bottom line is that, and there's no golden rule there's no gold standard, let's say, for how often to see a man who's on active surveillance. I would say that an earlier assessment with a biopsy is reasonable, and then start spacing them out after the first couple. So we in our group do a biopsy at about year 1, a biopsy about year 2. And if all those biopsies look good, then we start spacing out every couple of years, okay? There's this issue about whether we should do an MRI. And again, I think there's a lot of controversy there. We just published a paper that showed that the MRI finds as many as it misses. Right now in this country, it's multi-parametric. I say this country because there is the charge coding, as you probably know, what's driving this is somewhat billing. The biparametric really has not been embraced yet. And I think that there's a little bit of thing on the radiology side. They have to figure that out. But it is true, multi-parametric, you get all these phases, and there are really only 2 that are important. Can we just do those 2 and have a equally good image? I think so. I mean, the issue, we were talking about this the other day, an MRI in Europe costs about $200. An MRI in Canada, somewhere around $500 to $700, depending, US dollars. And we all know how much an MRI is here, okay, in the United States. So there's great disparity. And so obtaining MRIs, as far as the impact on the healthcare system across the globe, is immensely variable. Here in this country, again, if we got MRIs on every man that has active surveillance, we'd bankrupt our system. We really would. And I just don't think that's reasonable for a man that has one little piece of Gleason 6 disease and one core of the PSA of 5. And has had a few biopsies. I don't think they need an MRI. And no one's proven that they should. We do have some models out now that we can tell a patient with reasonable certainty if they have certain characteristics. PSA, prostate volume, PSA density, PSA kinetics, age, race, family history, BMI. It's all in a calculator together, and it spits out that they might fall in that lower risk group, that they can avoid biopsy. They don't have to do those biopsies because they are painful. There's about a 1% to 2% risk of bleeding, significant bleeding, like coming in the hospital bleeding. And there's about, depending on where you look, probably an equal 1% to 2% chance of having a hospitalization or significant infection. There are a lot of minor infections, though. And again, we're placing a needle through the rectum. It's not unexpected that we're going to get these. Although now, more and more, not only in Europe, but also here in the States, we're doing these transperineally, as you know, right through the skin. And the infection risk is less than at less than 1/10%. So it's 0.2 radiologists look at an MRI, a multiparametric MRI, and there'll definitely be different reads on that. With pathology, it is a morphometric read. I'll end with saying that my thinking is, Daryl, that we will conquer that with some computer-aided approaches. I wouldn't say artificial intelligence, but maybe artificial intelligence, but we'll fix some of these interpretive issues, I hope. As imaging gets better, we might biopsy somebody and say, oh, you don't have 3-3 disease. You have, 4+3 or something like that, or 3+4, but it's in this little discrete part of your whole prostate. Let's do something to that area. And I think if we get imaging better and then we get better energy delivery, that's coming. I don't know, probably won't be in the next 5 years, but it probably be in the next 10.